Good afternoon, everybody. We're going to get started at least informally. Very privileged today to have Dr. Daniel Morgan over from the University of Maryland. He's professor of epidemiology and infectious disease, a founding member of the Director of Society for Healthcare Epidemiology, has been the board of directors there as well. More awards than I can name, and 200 plus publications quoted in many different areas with interest in probability medicine, medical overuse, diagnostic stewardship. I kind of came across some of your work as you had a recent JAMA perspective about diagnostic stewardship and error that really struck a chord with me in a lot of themes that I think about in medical decision-making and applied support, and realized you've done a line of work. You've been thinking deeply about this area for a long time. We'll dive into that a little more deeply, but before we do, could you just tell us informally, just tell us about yourself. Who are you and how did you arrive where you were, and let us get to know you as a person before we dive into the science.
Sure. Let's see. So I go by Dan. I'm I guess professor at University of Maryland. My background is really in clinical infectious diseases and clinical medicine. I guess started doing infection control research when I started working here, and mostly because the group I was working with did a lot with infection control, and but I think my interests were always a little bit more broad towards like how we provide clinical care and issues around like what's appropriate and what is probably not best for the patient, and issues around overuse. And then one summer I was trying to figure out a way to sort of make the thoughts around sort of overuse and how we care for patients something more concrete that could be formed into a grant. And I got focused on the idea of sort of diagnosis and treatment and probability, and some of these early studies that suggested clinicians were not that good at thinking about these things. And then we tried to put those into sort of more concrete terms that could be studied in a way. And we're lucky enough to get a grant that led to a lot of this work. And I guess I'm a dad of 3 children in Baltimore, and been here for about 14 years, and fits me pretty well.
Fantastic. Are you practicing now as well, or previously?
Yeah, I mean, I certainly don't, I wouldn't compare myself to the people who practice full-time for a living, but I see patients at the VA on an inpatient VA infectious disease consult service.
Very good. We always say call ID when you want somebody to actually think about the patient or to collect an actual history. So it's very key to have that service. I think we start transitioning to more of the formal session, but some of the thoughts I want to just prime it with is very often in kind of work we've done clinically and in science, comments, which I think are flawed, that need to be deconstructed, that can be deconstructed. I've heard people say, you know what, Dr. Morgan, it never hurts to have more information. Why not just check? If there's even a 1 in 1,000 chance the patient has something bad, you cannot afford to miss that. You better just test them for it. If you even let one patient die by missing a test, you're in big trouble. How much does a blood test cost anyway? What, $10? What are we even talking about this for? It's not even 2 to 3% of healthcare spend. Why should that matter? I'm busy saving lives here, Dr. Morgan. Can't you go hassle somebody else? And anyhow, I think you'll have very many thoughtful perspectives on this and many others, but just to prime, but these are very real and very contentious issues. Medicine is plagued by these situations where very uncommon things can be very bad. But if you had to have absolute certainty, you just could not practice medicine at all, because that is never achievable. And given that, what's a thoughtful and responsible way to do that? Take it away, Dr. Morgan.
All right, great. Well, I hope to touch on some of those things. Feel free to bring them up later too. Because I think that there's just a lot of broad issues around different ways to practice and things that inform patient care that may not be the science, but certainly make a lot of decisions and are fairly widespread. And so I'm talking about diagnostic stewardship. It's kind of this newish term. We'll dive into sort of what that is but I think that there's just kind of a broad sense of what diagnostic stewardship may be too, that's a little bit bigger than a lot of the sort of the kind of quality improvement type stuff that I'll talk about. See, disclosures. A lot of my thoughts come from working with different, both of these people are ID doctors and clinical microbiologists, and I have grant funding, but no other conflicts to disclose. So this idea of diagnostic stewardship, came about probably around like 2017. It had been something that people have been thinking about for a little while, I think with different terms and not sure how to describe it. And so what I'm talking about is this, what we defined back in 2017 is modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. So really focusing on what's the outcome that we get from testing and how can we try to improve that outcome by changing the way that tests are implemented into a system. And so essentially trying to make certain that people get the right test for the right patient, prompting the right action, which is really the tricky part, of course, right? Because how people respond to test is not always obvious and, sometimes varies by person. So lots of articles have referenced diagnostic stewardship. This is just a sampling of them, where this appeared in the title. And what are the origins of diagnostic stewardship? So I'm talking kind of specifically about this idea that's mostly been infectious disease related, and focusing on how to improve the way that we test for and treat common infections. So, I think what sort of led to it was that for a long time, testing is known to be fraught. Clinical microbiologists talk about this a lot. And there's been this idea of diagnostic versus analytic accuracy, which, you could spend like 20 to 30 minutes talking about, but essentially how well a test works in a human versus how well it works in the lab on a laboratory sample. And for a long time, clinical microbiologists have been focused on better test use. And so we're sort of co-opting a lot of their ideas, but I think that they haven't really been that good at getting those out to the general clinician. And the new diagnostics have made this more of an issue because, things like these, PCR-based tests, multiplex tests where you're running lots of concurrent amplification tests or even sequencing where you start to get into like lots more data. And it's really pushed the issue because you start picking up very small signals, just little bits of RNA or DNA, and you get into this issue of positives in the absence of disease and how you deal with that. And then it'd be impossible to ignore the role of metrics. So hospitals are, penalized or get bonuses based upon their metrics. In healthcare associated infections, there's some of the key metrics, things like central line infections or, urinary catheter infections, et cetera. And so a lot of these metrics are based upon actual diagnostic test as part of their definition. And I think people realize pretty quickly that you need to change the way tests are used if you want to change these metrics. So around the same time in 2017, a few different people wrote articles on this. I was one of them. Kevin Messicars is a pediatric ID doc in Colorado who wrote a good article talking about diagnostic and antimicrobial stewardship for rapid molecular tests that I think was well written and has been referenced a lot since then. A group from the Netherlands talked about this too. I only found out about this a few years, like this year actually, but where they'd proposed diagnostic stewardship in sort of this complex pyramid. And then we wrote a piece in JAMA back in 2017, talking about diagnostic stewardship, and then had this follow-up one that I think you were mentioning, Jonathan, that was just a few months ago. So, and I would just point out, knowing there's probably a mixed group of people, and sometimes I give a talk like this for clinicians, that if clinicians perfectly interpreted tests, there would be no role for diagnostic stewardship. So, if people were good at figuring out pretest probability and being able to adjust that probability, based upon test sensitivity and specificity, and then make the right decisions, there'd be no role for diagnostic stewardship if we were all sort of perfect at calculating this and we actually have this information available. But doctors seem to poorly understand probability. So this is one example of that. We did this survey where we had very basic clinical scenarios that we presented to clinicians. We enrolled clinicians prospectively in eight different US states and enrolled over 500 clinicians. So it was kind of a bear of a study to get done because clinicians don't like answering these questions. So we asked, does this patient have cardiac ischemia? And for those non-clinicians in the room, this is a pretty straightforward case. This isn't kind of one of these board review type questions that's complicated and there could be lots of things going on. We're talking about one specific disease. And the case is a 43-year-old premenopausal woman who presents with atypical chest pain and normal ECG, no risk factors, normal vital signs and examination. So really what we think of as kind of a low-risk person for cardiac ischemia. And then we said she has a stress ECG test. How likely is she to have ischemia if that's positive? How likely is she to have it if it's negative? And so we're trying to put into plain language some of these terms that we talk about when teaching testing in a pretest probability and positive and negative predictive value. And so these are the results. So the gray area is a density plot of people's answers with some rounding. And so you can see that people tended to answer sort of from like 0 to 50%. There's like a little bump around 50%. And then, a lot of people answer around 20%. So the pretest, like how likely they thought she was to have cardiac ischemia, just based upon this scenario, they'd say the median answer was about 10%. The yellow box here is the best estimate from the literature, which is really about 0 to 3% chance. I think we all agree she's very low risk. And then this next plot was, we said she has a positive stress ECG test. How likely is she to have this? And you can see that the gray, the answers that people provided, the clinicians provided, shifted way to the right. And the median answer, I think, was around 80%. When the true answer based upon the literature is probably 2 to 10%, and that's in this blue box. And then even a negative test result really didn't change people that much from what they thought before the pretest probability. So what this all illustrated to us is that clinicians aren't that good at interpreting tests or even sort of thinking about the probability of diagnosis. They way overestimated the initial probability, and then they estimated it much stronger after a positive test result than they should have, and even didn't really decrease the probability that much with a negative result. So in this survey, we asked a few other scenarios, like one for UTI, one for use of mammograms, one for pneumonia, and found pretty similar results throughout. The clinicians aren't that good at thinking about probability or adjusting probabilities with test results. And we also found that those clinicians who were more aggressive at testing, this was associated with a few different cognitive characteristics of those clinicians. So there's a scale that's been created called the medical maximizer scale. And we found that people who scored high on this were more likely to test aggressively, so not that surprising. There's scales for numeracy, and this is the ability to sort of modify numbers in a simple fashion, like say 10% of people have a disease, how many out of 100 have that? So, relatively straightforward, but ability to manipulate numbers that you would encounter in real life. And those who didn't acknowledge uncertainty tended to test much more. And also your background training correlated with this, with those who were nurse practitioners and physician's assistants tending to test more aggressively. So all things that aren't terribly surprising, but I think hadn't been described very well before. I would even highlight that in, talking about this issue, like are clinicians good at diagnosis, or do they need some degree of diagnostic stewardship? That we even created a diagnosis for wrong test interpretation. So in infectious diseases, we have this problem that occurs all the time, that urine cultures are positive quite frequently in hospitalized patients. And these patients very rarely have UTIs. And it's just that it's a bad test to distinguish if someone has UTI versus being colonized. People who have a urinary catheter in place for a long time, or who have an older or less functional urinary tract, usually have bacteria growing in their urine, which doesn't really mean anything. But it often leads to people being treated for a urinary tract infection if someone tests this and then finds a positive test result with cultures growing. So the Infectious Disease Society of America back in 2005, and then updated more recently, put out a guideline for what we were calling asymptomatic bacteriuria. And this is a positive urine culture without a UTI. So we tried to get people to recognize this, that it's a positive test without a disease by creating a new diagnosis. And, the recommended treatment for this is nothing. You're just supposed to observe. But, it hasn't been all that successful. People still treat asymptomatic bacteriuria all the time as one of the leading causes of antibiotic overuse. But it's clear that test results are difficult, and information alone is not always helpful. So I think we do need diagnostic stewardship. So I would also highlight that test interpretation is complicated. So I was just talking about how bad clinicians are at it, but there was a reason we suspected they wouldn't be that good at even very bread and butter cases. And so here's some knowledge that is essentially required if you're going to try to have a scientific approach to estimating probability while you're testing someone. So you need to be thinking about things like, was the sample collected or transported appropriately? This isn't that hard. You need to think about how accurate is the machine versus another machine. And so this is this analytic sensitivity type question, which often is not called analytic sensitivity, it's just called sensitivity or specificity of a test. But essentially this is like, a COVID PCR test, and saying, well, the test is perfect at picking up COVID RNA. So therefore it's very sensitive and very specific, but we all know from real life that RNA can be persistent in people who don't have COVID, but had COVID in the past 90 days. And so these numbers don't actually relate to real life use of the test. So the harder parts are thinking about this diagnostic sensitivity and specificity, which is how well does a compound or a finding distinguish disease from not? So say a population of 100 people who have the disease, how good is the test at picking up those cases? And that'd be called sensitivity. And then out of 100 people who don't have a disease, how often is the test positive? And so specificity is essentially the inverse of that. So that'd be the false positive rate of 11% or a specificity of 89%. And so, these three steps tend to be summarized by clinical sensitivity and specificity. And then the last steps are applying this to an individual patient. So that's thinking about how likely the patient was to have a disease prior to testing, and then modifying that probability based upon a positive or negative test result. So it is complicated to think through this, and I think it's something clinicians really aren't trained to do. At best, usually there's an hour or two in medical school where these concepts are proposed, and then we beat it out of students during the clinical years where they don't see other doctors taking this approach. So I'd say we tried to facilitate understanding of diagnosis too. They're trying to create some tools, which I'll just show you a quick example of, but in the interest of time, not too much. So we created a website, Testing Wisely, and based upon different suggestions, and this is funny because I really am kind of computer illiterate, but spent a lot of time working with gamers and graphic designers to create some of these things. And we created a video game that attempts to teach people how to adjust probabilities using some kind of basic psychological concepts, essentially decision analysis, but it's been called natural frequencies by psychologist Gerd Gigerenzer. And so we created a game that you can watch an intro video to, you can take a tutorial, but if you jump right into the game, it starts out with a brief description. It's 5 minutes, 10 questions total, telling people they need to guess and that they can't do full calculations typically. And then you can set a timer or have real life questions or sort of more math oriented questions. And if you have positive or negative test results or both. So, and this is how it appears. So it still doesn't feel exactly like there's a patient in front of you, but it gives you the idea that this patient has a fairly high pretest probability for pulmonary embolism based upon these factors. The test is a D-dimer test, which is quite sensitive, but not very specific. And you get a positive test result. How likely are they to have disease? And so you could guess, you say, wow, it's positive. It must be very likely. And then you get feedback, well, 87% is too high. So let's try again. See, 25%, let's think, maybe it sort of doubles. Okay, well, still kind of guessing too high. And, let's guess a bit lower. So this one is kind of encouraging guessing and giving feedback along this range, but then it actually gives you a sense of how to interpret this. And this is using the natural frequencies. with the idea being if you started out with 100 people, how many would be sick, how many would be well, how well do you identify those people who are sick, those who have pulmonary embolism, and out of those who don't have it, how many have a positive test? And you see that a lot of people have false positives, but you're pretty good at picking up everyone who has it. So that's how you get to a number of 35%. And that's described visually here with this waffle chart. So I'll stop there and just go back to my talk, but just to give a sense of some of the tools that are out there, and we're hoping to try to create tools that can be used to educate better on using probability for diagnosis, which really is the evidence-based method for approaching this, and really more and more how we're seeing the machine-aided approaches give feedback, how clinical decision support, or certainly probably AI, will end up giving guidance to people, that it will give them information in terms of probabilities. Okay, so diagnostic stewardship is based on the diagnostic pathway. And that's this idea that most patient care is based around a clinician seeing a patient and then deciding if they need to order tests, that the clinician will order test. And traditionally, I think the approach is that the tests just come back and the clinician interprets these, that there's not that much that happens sort of in between ordering and reporting. And diagnostic stewardship is the idea of trying to focus in on, what I think of as sort of an iceberg of all these things that happen behind the scenes in a hospital or healthcare system. And that is that there's a lot that happens with the electronic health record and in the clinical microbiology lab, and there are steps that can be intervened on to try to improve testing. And so there's some things like for test ordering that you can modify decision support and provide some of these behavioral economics approaches of nudges or framing to try to discourage people from choosing to use tests inappropriately. People even use soft or hard stops, so basically blocking testing under certain circumstances. And you can clearly change the way that people order tests. And then the laboratory can perform tests differently. So it can perform sequential testing, that it always do one test followed by another test to try to improve the testing characteristics. They can refuse samples, like if sample criteria aren't met, like say if they're running a C. diff test and there's the stool is not liquid stool indicating diarrhea, they won't test it. And then the way we present results hasn't really been thought about that much. I feel like a lot of times we sort of get like a machine readout of what a microbiology culture is, without much thought about what clinicians need to know or what will shape clinician decisions towards better, patient care decisions. So we can, again, sort of frame results in a certain way. We can limit results that are displayed and provide interpretation towards better test interpretation. So this is all what I think of as diagnostic stewardship, so a pretty broad view. And so people have used this and found, that it has a pretty remarkable effect in terms of preventing healthcare-associated infections. And I think even more importantly, it sounds a little bit backwards, preventing antibiotic use in patients. So this was a study, it'll be coming out in JAMA Internal Medicine, I think in the next week or two. I know it's been reviewed and accepted. So this was Valerie Vaughn, who's at Utah now. She looked at this Michigan consortium of hospitals where they were trying to improve the treatment of patients with asymptomatic bacteriuria, that category that I described earlier of patients who do not have a disease and have a diagnosis actually that's saying don't treat with antibiotics. And so they've created a quality metric that actually has been approved by the national by NQF, and I think will start being implemented for ASB. And they looked at hospitals and started feeding back this rate to people, how much of their positive urine cultures that were treated with an antibiotic were ASB versus UTI. And these are their results. And so when they started this study across these 46 hospitals, they found that about 30% of patients who had positive urinary cultures were being treated for ASB and not for urinary tract infection. They had a series of quality improvement type interventions. They started doing pay for performance, so people's rates would help determine the reimbursement they got, as well as giving feedback of these rates to them in comparison to peer hospitals. And they found that over a 3-year period, they went from around 29% to 18%. So they saw a pretty significant improvement in the treatment of asymptomatic bacteria. And notably, they tried to look at, is this diagnostic stewardship or antimicrobial stewardship? With the idea being that diagnostic stewardship would be if the test were not being ordered in people who didn't have symptoms. So essentially, are the tests being ordered more appropriately? Antimicrobial stewardship would be like if the tests are still being ordered inappropriately, but they're not treating those patients with antibiotics. And either of these would be good outcomes, right? The goal is to not treat people who don't need it. And a test result, as long as it's not acted upon in the wrong way, is not harmful. But what they found is there was no change in treatment of people who had asymptomatic bacteria. They were still being treated just as often, but there was a decrease in the testing that led to decreased amounts of asymptomatic bacteria. Some similar type results have been used for C. diff testing. C. diff really is, I think, sort of the poster child for diagnostic stewardship, and that's because it was so obvious that the way we tested for C. diff led to differences in rates. So this is a project led by Claire Rock out of Hopkins as part of the CDC Epicenter Collaborative. And so they looked at 15 hospitals, and they were trying to improve the use of C. difficile testing by focusing on removing duplicate testing and not treating people who are on laxatives. And they had a few different interventions, but their primary goal was to restrict people from ordering the test if someone was on a laxative, assuming that if a patient was being treated for diarrhea, that you shouldn't start testing them for other causes if they were on a medication that could cause that diarrhea. And so what they found was a 25% reduction in testing for C. difficile. And this is usually a PCR type test. So it picks up both colonization and infection in an indistinguishable fashion. And they found a similar reduction in use of antibiotics for C. difficile, which is, I think, the most important outcome for patients. And then the most important outcome for the hospitals were a 30 to 60% reduction in these CDC reported quality metrics of C. difficile infections. And they found that hard stops, so if you tried to order a C. diff test and someone was on a laxative, they would say, you can't order this test while they're on a laxative, please call the micro lab if you still wish to proceed. So people always are given the option, they can get the test if they really want it, but it will take a few minutes of their time to get it. And they found the hard stop was much more effective than other interventions. And then the last study that I'll talk about is dealing with blood cultures. And essentially sort of sepsis and central line infection type issues that we deal with. So this was in children in pediatric intensive care units. It was led by people at Penn and Hopkins, but obviously they had a collaborative group of hospitals. And they really focused on when people were ordering tests, like to order tests appropriately and not order them when they weren't needed, and that they be performed appropriately, that the technicians who were collecting blood cultures would know how to do them better, so they were less likely to have skin contaminants and other essentially false positives that could lead to a positive blood culture that tends to trigger antibiotic use. All right, so what they found is described here in this kind of busy JAMA table. So just to summarize, I think the key findings. They found that people cultured blood, did blood cultures about 33% less often, so about a 1/3 decrease. And that CLABSI rates, central line associated bloodstream infections, decreased at about the same rate. And they found there was a decrease in overall broad spectrum antibiotic use by about 10%, with no harm in other measures where they're looking at, are people getting, having untreated infections or other potential harms. So pretty remarkable. They found a 30% decrease, reduction by 1/3 of blood cultures, central line infections, with a less significant change in antibiotics, all based upon teaching people to better order test. So in summary, you can see that diagnostic stewardship for these common infections that admittedly have somewhat flawed tests led to decreased antibiotic use and decreased reportable healthcare associated infection rates. So there's been some talk about diagnostic versus antimicrobial stewardship. I think half the time you say diagnostic stewardship, people are thinking about antimicrobial stewardship. And this, just to emphasize, is a little bit complicated and probably not the right audience to spend much time on. But when patients are being evaluated through to the point of being diagnosed, there's a lot of different steps that occur. And diagnostic stewardship is really focused on changing the way that we diagnose patients, the way that we use test and human cognition to better diagnose people to try to get better outcomes. Whereas antimicrobial stewardship tends to focus on after a diagnosis is made or there's an initial assessment, trying to get people to use the most appropriate antibiotic for the most appropriate time frame. And this table probably isn't worth spending a lot of time on just because of the audience, but it's just emphasizing that antimicrobial stewardship, which is much more established, has a lot of approaches like audit and feedback and prior authorization and timeout, these different practices to try to get clinicians to change what they're doing. Whereas diagnostic stewardship tends to try to modify the way that they think about testing and diagnosis kind of early on. And this is a paper that's coming out as part of a task force that I lead with the Society for Healthcare Epidemiology of America. Okay, so I talked a little bit about healthcare-associated infections. I think it's worth mentioning more just because that is a driving factor in what's led to, I think part of the uptick in diagnostic stewardship. And that's that there's very little in healthcare that really drives towards less, right? I think in the beginning, Jonathan talked about people being worried about like, a 1 in 1,000 chance of missing something, or, in any chance of helping somebody should be taken. And obviously that's without regard to the potential harms of the actions that are being taken. So a diagnostic stewardship in these HAI reporting actually has led to hospitals being aware that more is not always better. And so, with these different healthcare-associated infections that impact the hospital's bottom line are things like central line infections, catheter-associated UTI, hospital-onset C. diff infection, hospital-onset MRSA bacteremia, and a surgical site infection. So diagnostic testing in part has an impact on all of these. And and so these metrics really do have a big impact on how we think about diagnostic stewardship. And I think metrics aren't perfect. This is this law, Goodhart's law, that I think is relevant if we're talking about metrics, that any observed statistical regularity will collapse once pressure is placed upon it for control purposes. And that's clearly what happens with healthcare-associated metrics. These are not numbers that are ignored. In fact, like in someone like me, one of my jobs is to be the healthcare epidemiologist for my hospital. And so if our rates are high, I will be called in to meet with leadership to talk about why our rates are high and what we can do about them. So these get a lot of attention. And obviously, once you start trying to change numbers, like what we've seen with no school left, no child left behind, there's a lot of things that are changed and they may not be for the best, and the numbers may become less realistic. So a little bit about other types of diagnostic stewardship, and apologies if you hear that ambulance in the background here, part of being at a hospital. So there's good examples of other types of diagnostic stewardship. So one of the common things that plagues hospitalists in residents and training programs is this daily laboratory monitoring. For a long time, patients essentially got lab testing every day, regardless if there was a need to or not. And people have tried to take this on, mostly general internists, and doing things like training on when they should be ordering testing, and then actually trying to change the electronic health record to limit the ability to order tests. Like, you can't set up daily lab testing when they come in. You have to order each test separately. And they found that they can reduce daily labs, decrease misdiagnosis of electrolyte disorders, and even improve anemia. So we test people so often in the hospital centers that we lead to them having anemia or low blood counts from that frequent phlebotomy. And another example that I think is great because it's been worked out pretty well is pulmonary embolism. And this is one when I was training, everyone said, worry about pulmonary embolism. Always think about pulmonary embolism. And we didn't have great tests for it then. It was the era of the VQ scan, which is like this ventilation perfusion nuclear medicine study that is very vague and somewhat difficult to interpret. So people worked out, well, if someone's low risk, how can we try to avoid doing other testing to to look for pulmonary embolism that may lead to harms from that test result. And so people created this rule to help risk stratify people. It's called the PERC rule. And it essentially categorizes people as low risk for pulmonary embolism. And those patients, they're recommended to have a D-dimer test. And D-dimer is a crappy test generally. It doesn't have much role in medicine. We do it all the time, but it really doesn't have much role outside of this setting, that if you have a low-risk patient, you can pretty well exclude pulmonary embolism. And then if you exclude that, then you don't need to do a CT scan. And CT scans can be associated with different problems. Some of it's exposure to contrast and just needing to go through a procedure. But I think probably the biggest problem for patients is misdiagnosis of these very small pulmonary embolisms that we're not really sure what to do with, but we always treat with blood thinners, which obviously are not the safest medications. And discovering incidental omas, omas that are incidental, but yet often cannot be ignored once you find them, as well as improving emergency room times and hospital admissions. So that led to this, this paper is where I talked about that. This is the recent JAMA perspective that Jonathan mentioned. And I wanted to try to tie this into diagnostic error. There's this movement towards diagnostic error, which I think has taken up a lot of momentum, at least in the federal government, with HRQ funding a series of centers of diagnostic excellence. And this is the idea that diagnosis is not simple and that we often have errors in diagnosis as clinicians. And these are defined as misdiagnoses. So when like a diagnosis could be made, but we miss it, delayed diagnosis or wrong diagnosis. So probably the most common example is something like a chest x-ray that's done in the emergency room. Someone has a nodule seen, but nothing is done about it. And then the patient comes back in 6 months later with metastatic lung cancer, where obviously that would be a harm to the patient, when the cancer could have been picked up earlier and potentially prevented or at least managed better. But I think wrong diagnosis is a big part of this that is somewhat overlooked by the field. And then that's that if you give somebody the wrong diagnosis, you often stop looking for other things. And in infectious disease, there's a series of interesting papers looking at patients who are eventually diagnosed with tuberculosis or histoplasmosis or epidural abscesses, and finding that they often have wrong diagnoses preceding the correct diagnosis. That people are often treated for sinusitis or lower respiratory tract infection or things that they didn't actually have before they eventually had the workup and the appropriate diagnosis made. And if we think about one of the examples they gave in the National Academy of Medicine report on diagnostic error was Duncan Thomas, who was the first patient to have Ebola in the United States. Probably many of you remember this, the guy who came back from West Africa and feeling sick and then went into a hospital in Texas. And in that hospital, he went in and he had a low white blood cell count and actually renal failure. And they diagnosed him with sinusitis, gave him ciprofloxacin, and sent him home. And he came back 2 days later with really full-blown Ebola, which he eventually died of. And a few staff people at that hospital contracted Ebola while taking care of him. All right, so what's necessary to implement diagnostic stewardship? This is still kind of an early field, so it's a lot of different stakeholders needing to be involved, usually microbiology, antibiotic stewardship, infection control, information technology, and then the clinician end users who are most impacted by this. You need a lot of hospital and leadership support. You need to talk about defining the measures that will assess the impact, both positive and any negative impacts, to make certain they don't occur, and then review and refine the intervention over time. And so I do think diagnostic stewardship will grow with increased hospital support. There's interest from the CDC in trying to promote this. And it'll probably go beyond the most common uses, which is catheter-associated urinary tract infection and C. difficile, to a range of molecular tests, radiology, and chemistry tests. And hopefully there'll be sort of more funding for standard training for the people who actually would do a lot of this, and more research training more research funding to try to have better knowledge around how to do this. And so with that, I'll stop, and hopefully there's plenty of time for discussion. Thanks everyone for your time.
All right, thank you, Dr. Morgan. Questions in the room or anybody online, if you want to drop something in the Q&A, the chat, and I'll open up your mic if you'd like to get that through Oh, I have like 10 questions. I think there's a lot of great things to discuss, but just want to make sure nobody else wants to jump in first.
Question.
Please, Allison, go ahead.
I was just curious, thanks, it was a great talk. I was curious how much work has been done thinking about also the role of patients in this process, in terms of like patients who say, test me for everything, or I don't feel comfortable without being tested for this thing I'm concerned about. Especially when you looked at those trends of like, what are the types of providers who are likely to have aggressive testing? Was there any association with types of patients there?
Yeah, I mean, so this is a great question, and I don't have answers from sort of that study because we just gave, that was really just testing providers on these very standardized patients that we had notably say like they don't have any opinion and want to know what you think. But there are some interesting studies, I mean, that come out of like, say, the cancer prevention screening literature and some of these other areas where they look a lot into like appropriateness of medical care that Debbie Kornstein is a general internist in New York City who's done a lot of this. And it seems that, I mean, sort of the takeaway is that patients do often ask for tests and they think that, you know, testing is necessary for them. But what they really want is kind of care and attention and focus on their needs and symptoms. And I think that's often confused with testing. I think testing is kind of like a cheap, easy way to do that. Like if, you know, someone comes in and they're worried about something, you say, hey, I'll send you for the test. And then you're essentially done and you don't need to do anything until the result comes back, versus to not test patients often requires more time and talking with them and figuring out what their priorities are. And then I think a lot of patients, if you do spend time with them and, you know, and they're able to understand it, you know, aren't as interested in testing necessarily. I mean, there's really a range, and some people will, I think, want to be much more aggressive with their medical care and accept the potential harms associated with that. Whereas others really, you know, aren't that interested in doing things unless they feel like they need to. So, I mean, I think a lot of it's a lack of information, and the clinicians could do much better at actually talking to people about, you know, what really is going to help them and what may, you know, have a very marginal effect.
Just a follow on to that, it's a great discussion to think about. I was thinking about what's happening with more and more direct to consumer testing, and I can just pay out of pocket and get a full body scan, full genome sequencing. I can have my watch tell me if I have an arrhythmia. Like how does it matter, or that's good? It's democratization of access to medical care. What do you think the implications of it? I know it's a big broad question, but what's your interest in your thoughts on it?
Yeah, I mean, I think it's, I mean, I guess, you know, I first thought about this, like, you know, with Theranos back, I mean, there's one where I agree with, you know, your colleague, John Yanodis, who wrote about Theranos back before it was seen as fraudulent. But, you know, just the idea that you can test for a lot of different things all at once, you know, daily on people, just seemed like a horrible idea to me. You know, that you're gonna lead to a lot of confusion with that information versus useful information that can help somebody. You know, I think that there'll probably always be some degree of that. I mean, the executive physical type thing where, you know, go get your MRI and find out what's wrong with you. You know, and certainly like, you know, the Apple Watch picking up an arrhythmia, you know, people have talked about the problems of essentially screening low risk people for something that, you know, the false positives become much more common than true positives. I mean, I think it's hard to get away from the idea that most people have that sort of technology is, you know, really remarkable and doesn't need to be used with nuance or kind of interpreted appropriately. So, I mean, I think it's just always a bit of an uphill battle, and people will be interested in that. But I do think if people get feedback, you know, they'll tend to, you know, ignore it some too. Like, you know, if you have your Apple Watch and it's always telling you have AFib, after the first, you know, alarm goes off, you may start, you know, not being interested in that and turning it off as a function because it's not helping you.
Definitely gone through that example you do, and it's a key part of our informatics training too, is the rare disease screening and how the PPV is not what you think it's going to be, and there's really no way to intuit that unless you do the math. I remember reviewing that with some medical residents because they made exactly the same wrong intuition, and one resident is like, "Oh, I know all this math stuff, you know, I'm going to just stick to doing the medicine." I'm like, if you don't understand this, you don't know how to practice medicine. And yeah, as a side, Rob Gallo and Jorge have a question. Rob Gallo, do you want to go ahead and ask your question?
Yeah, thanks so much. You know, one of my experiences as a clinician is often diagnostic stewardship is defined a little subjectively, or at least the, you know, some of the endpoints are subjective. So like, an example is asymptomatic bacteria. Sometimes there's some gray areas where you're not sure if maybe some symptom could be from UTI, or if the urinalysis is just asymptomatic. Like someone coming in with maybe altered mental status. Do you know how that's kind of handled generally? Like maybe in that Vaughn study you mentioned in JAMA, especially considering like gamification of metrics is maybe a concern.
Yeah, I mean, it's a great question. And I think, gets it, some of the challenges of doing this, I think that there are, there's kind of clear low-hanging fruit, which is like just really inappropriate use of testing. But then, when you get into sick people in the hospital, it often is, a bit more nuanced, right? Like you have like a sick nursing home patient who comes in and they have mental status changes. Well, could it be a UTI? And I think it's very hard to say it's not for sure, but it's also can be quite hard to say, it is. And I think that gets into this issue of, just medical uncertainty, that a lot of the care that we provide is in the setting of uncertainty, that we don't really know what somebody has. I mean, I think that the example of mental status changes with a positive urine culture, people have talked about a fair amount, and essentially, there's some guidelines even to generally not check a urine culture just for mental status changes. But if you have somebody who also has like, a low blood pressure and a fever, it makes a lot of sense to test and even treat that person, even though, you may be over-treating them. They may not need it, just like a lot of medical care where, essentially defining a population, and we're not that precise about how to really target it perfectly. But, I think treating sick people makes a lot of sense. And, but, being able to be a bit more cautious and careful with providing care or not for people who aren't, immediately sick. But I think that, that at least just being aware of the issues and trying to be able to sort through those knowing that there's often no perfect answer, and it may be different by the patient or, different by the setting or the family, et cetera.
In like a lot of recent studies on urine cultures, there's antibiotics, that's some type of prediction, and they just use the urine culture result as the target, but that is clearly wrong because we've shown 30+ of the time it's a false positive. It has to be accounted for. Just to pin that question that Rob asked, in that particular study, was it just manual review, or how did they get the label asymptomatic bacteria or not? Who came up with it, or where did it come from?
Oh yeah, I mean, so that one, Valerie Vaughn has spent a lot of time with this. I mean, I think she managed to get money to try to create a metric. And so they actually had, as part of this University of Michigan collaborative, they have people doing chart reviews at each hospital. And so they would, like, I think, pull the first 10 positive cultures per day, and somebody would review the charts to look for symptoms. And again, probably it doesn't completely mimic real life because, not all symptoms are mentioned. And if you're seeing a patient, you may, elicit different things, but at least it's, in terms of a metric, probably gives a pretty good idea of, if people had typical symptoms or not.
Got it, great. I want to move to Jorge Salinas, our hospital epidemiologist, who was very excited that you came today, and go ahead and ask your question live, Jorge.
Yes, hey, thank you for organizing, and thank you, Dan, nice to hear you, great talk. So I'm curious about clinical decision support, BPAs, etc. I've seen in the publications people say, yes, do a BPA, but why does every hospital have to come up with their own design of a BPA? Why doesn't Epic or Cerner? Why is it so difficult to make this happen and so unstandardized? Thank you.
Yeah, no, great. Good to hear your voice, Jorge. I mean, sort of the one person in this virtual room who I know from the SHEA hospital epi community. And it's funny, that question, because with the CDC, we've been trying to build like an Epic BPA, sort of order set related thing to improve the diagnosis and treatment of pneumonia. And so literally yesterday we were on the call with like some of the Epic leadership, and it is interesting. They said they're building tools for diagnostic stewardship for urine and C. diff testing. I haven't seen those. I'm not sure exactly how people even access them, but there is some awareness that there's a benefit, and for Epic, it may be like a commercial benefit to sell this, kind of additional thing that can be implemented at hospitals. But I think there is interest in trying to build something like that can then be used a little bit more routinely. Because yeah, I mean that each hospital building their own kind of one-off BPA or intervention, clearly is not optimal, and there's clearly should be some economies of scale of how to do this in the best fashion possible, especially considering we only have a few different health records, electronic health records across the country.
Your perspective. Niaz Benai, I don't know if you want to get on here. He's the director of our clinical micro lab. Go ahead and ask your question.
Yeah, hi, yes, Niaz. Thank you for your presentation. Very interesting. So over the years, we have done a lot of measurements, and then based on that, what we have understood from the physician's behavior, we have introduced interventions to enforce diagnostic stewardship. I was wondering if you can tell us what is the most effective tool out of all those different things you showed at the ordering level, in the laboratory, and post-analytically.
Great. I mean, I always get nervous when clinical microbiologists ask questions about diagnostic stewardship, because they're like, okay, I know we took your idea. We're just trying to promote it to clinicians, better. But and I like your work. But I mean, I think that it probably depends on the test some. I mean, clearly, if you talk about some of these, more advanced molecular tests like Carius testing or the metagenomic testing, where there's essentially like you need to get pre-approval from the lab to order it. Well, that stops a lot of testing that would occur, I'm sure, that ordering step. Whereas I think, with other tests, it's probably, a bit different. I would say like urine cultures is probably where I've spent the most time. And I think I've just spent time with them because they're such a bad test, and they clearly lead to antibiotic use as an outcome. And it seems like, the laboratory step of only processing urine cultures, if there's pyuria, is probably, reduces, 30 to 40% the amount of cultures that are performed, and has a smaller impact on the number of infections that are diagnosed. And probably, limiting the ordering by requiring indications to be documented has a similar effect, probably like a 30 to 40% effect if the BPA is built well. I think the reporting changes. I guess it's less frequently that you see an impact by the way that results are reported, unless you get into pretty dramatic approaches. Like there was a hospital in Toronto where they decided that urine cultures often were being misinterpreted. So they created a rule. This is kind of a famous study, so probably Jorge and Niaz know about it. But where the urine culture, when it was finalized, when the microbiology lab had the result, they would put in the chart, in the electronic health record, the result is available. These are often overdiagnosed as asymptomatic bacteria. Call the lab if you want the result. So essentially, like, putting a barrier to getting the test result, but not saying it's unavailable. And nobody called the lab, and nobody, and there was less treatment without any harms in that group. Notably, I don't think that hospital still takes that approach, and most across the United States, I hear most people thinking that it would be illegal to not report a test result back to clinicians who order it.
Thank you. May I ask a follow-up question?
Yeah.
Do you think what would be the role of a smart electronic medical record system that doesn't exist right now in diagnostic stewardship?
I mean, I think it, depending on how smart it is, it could be amazing, right? I mean, I think that there's, it's kind of hard to imagine, because I think in terms of like EPIC or CPRS, because I work in the VA mostly clinically, neither of which is very smart. They're kind of great catalogs of information. But no, I mean, I think that, you could imagine that the systems could do a lot to improve things, and, and just sort of by, sort of addressing the low-hanging fruit. I mean, I feel like I was talking with Adam Rodman, who I know mentioned working with some people out there. He's a hospitalist at BI Deaconess in Boston. And, and he's been playing around with ChatGPT as a way to diagnose patients, and sort of looking at like case studies. And it actually does remarkably well at sort of predicting probabilities and getting a sense of like what kind of things may be happening with the patient. So you can imagine, it wouldn't be that hard once privacy issues were addressed, and and if the system had access to patient records, to start having a much smarter system that could, recommend testing when it seemed like somebody was forgetting something, or, recommend against testing when someone was trying to order something that wasn't necessary. But I mean, we're still at the step really where there's like order sets all over the place to do urine cultures and someone who has no reason to do a urine culture. So, I think it feels like we're still kind of in the dark ages compared to what is theoretically possible with computing systems.
Definitely.
To follow on to that one, that we got a couple minutes left. Often information is not enough to change behavior, though, is often the finding, though. So even if the smartest computer system in the world, first are just going to do whatever they were going to do anyway. Is that true or untrue? Where do you find that holds up?
I mean, it depends on how you modify, the information they have access to. I mean, I think just information by itself, yeah, I'm skeptical of it is being that helpful. But I do think, I could imagine like a smart system where like, orders, recommended considerations are sort of available or not. I think if people don't see information, it clearly changes, their considerations. And, and if there's some, if you can sort of think about ways to frame the information in the right way, or make it a little bit more difficult to get to if it seems like it's of low value. I think trying to figure out the right balance of not trying to annoy clinicians who are just trying to do their job, but also to keep them from making bad decisions. Is something that's possible with the electronic health record, but it takes a lot of effort and I think kind of clinical studies to see like what are the results of changes that you make, like how does it actually change behavior in practice?
Could you comment a little bit more? You very briefly mentioned, if we're reducing antibiotics, reducing testings, like what about, are you facing clinical backlash from people who are annoyed with having to face this? What about underdiagnosis? How many diagnoses did you miss and has patient harm? It sounds like it hasn't been that big of an issue, but certainly something you have to manage as your sensitivity and specificity. And then closing thoughts, I'll turn to you.
Yeah, I think it's always important to address that up front. And I think as far as annoying clinicians, I think a lot of it is how you build things into the system and how you communicate with clinicians. Kevin Massacars has done some interesting things related to rolling out some of these multiplex panel testing and limiting their use. And if it's done closely with clinicians, they often appreciate the information that's provided and helping them use things more skillfully. But I think we have to be very careful to, that there is, people are much more aware of the errors of omission, like not testing, than the errors of commission. And so to be, extra aware of safeguards to, prevent missing a case. And I think right now with certain things, we overdo it so much that there is low-hanging fruit. And I think we should probably always err a bit on the side of doing more than doing less. But we go very far in certain circumstances now. So we could probably pull back and still really not start to have to really do like a harm-benefit type analysis.
We're at the hour, right? We clearly can continue the discussion. I hope this won't be the last of the discussion because a lot of great threads continue on. Lucy Tompkins asks, the old docs, we can't help them anyhow, but maybe are we obligated to at least train the new docs a better way to approach things? But maybe just turn to you, any final thoughts, and we'll call it for the hour. And thank you so much again for being here.
Yeah. No, as someone who's finding myself starting to identify as an old doc more and more often. I agree. Probably the best effort for things like, when we've been trying out this game for teaching diagnosis and stuff really is focusing on trainees. I think it's a lot easier to get people's attention and change the way they think about things before they have like established practices and before they get so busy they don't have time to kind of rethink how they do things. So it'd be great to change everyone, but I do think trying to focus on like the next generation is probably the better way to have a lasting change.
All right, fantastic. Well, thank you again one more time, Dr. Morgan. I hope to be in touch soon.
Okay, great. Nice meeting everyone. Thanks for your time.
Good afternoon. Thanks, everybody.
Bye-bye.